Hi people, can you all hear me? If yes, just send me a reply. I will also log in my phone so I can read your comments. I'm going to groups and I'm also seeing if the live is active. Yes, it's pretty much active. Yeah, can you hear me? Now I can see your comments and feeds. Write something yes or no if you can hear me. I'll start the SBQ solving session then. Can you hear me, guys? Just write a yes. There is no invite. Oh my god, people in the group. Go to Facebook Live. There is no invite. You can join. Yes, somebody said yes. So I'm going to start the solving session. And once I'm done with this SBQ, what you can do is you can just write me your doubts, okay? So I'm starting with SBQ 1. So after I'm done with this SBQ, I'll ask you a few questions. Just comment and then I can see everybody's comment and I'll answer one by one. So I hope your preparations are going fine for people who are going to appear for September. May is about to end, you know, so June, July, August, and then September would be the exam. You have 3 months. I hope you have done your warm-up now. Time to, you know, hit the treadmill and go on a fast track, which means that start studying more seriously now. And one question that I've been asked often is that it's really tough. How did you manage? And how will I clear it? I'm getting stressed about the exam. There's so much to study. First thing is, yes, it is tough exam. It's not a simple exam. Secondly, it's a very biased exam because you have 4 papers, and even if you score excellent in 3 papers and not good in 1 paper, you fail. So I would say don't focus on getting each question right, but focus on understanding each question, because you cannot get each question right, or even if you do, you never know what ADC has got the right marking list. If you would have seen on their website, they have released in the last 2 years, their passing percentage is just 22 and 40%. That's it. So, which is very less, you know, it's not even 50% passing rate. So don't be upset, okay? It's a tough journey, but you do your best. And one thing which I did, which helped me in clearing my exam, was not to follow too much of social media. Honestly, when you see 10,000 questions going here and there with different wordings and different options, and you are just focusing on getting the answer right, that is not the way to study. You focus on your study material, whichever mentor you are following, and just make sure you have the right study material and just follow that. Don't bother about who is posting, where it is posting, and then go and asking your friends what is the correct answer. You analyze. Nobody knows the exact answer that the ADC wants. Everybody who's cleared this exam with the new pattern is giving their own interpretation of the exam. So you see which works best for you. It may also happen that you're following 10 mentors and you're not satisfied with any one of them. It's fine. Follow your instinct, you know. So anyways, let's start with this SBQ. OPG questions will always come. And I'm starting with one of them today. So this is, I hope you can see my screen. And yeah, what is the error in this OPG? We'll come to the question. Now first, when you get a question like this and you see an OPG, even before you see the sub questions, you have to understand that you need to imagine a normal OPG in your head. Okay, this is the picture and you have to imagine another picture in your head which is of a normal OPG, and then you start comparing. So even if somebody would have given me this OPG, even if they would have not asked me any question, the first thing I would have seen was why I can't see the chin, you know. The lower border of the mandible. Clara Lopez says, I can see the screen, but it is blurry. No, it's clear, I guess, because I can see the screen pretty fine. Is anybody having the screen problem? Do you find it blurry? Because this is the picture and it's pretty clear, because I've opened it on my phone also to see how it's appearing to you all. I feel the picture is pretty clear. Anyways, so the first thing that would hit my eye when I would see this OPG is that I cannot see the lower border of the mandible, okay, which means the patient has come either too forward or he's bent his face downwards. Now, if the patient would have come too forward, then see my arrow where I'm taking it. This condyle area and the lateral border of the mandible would have also come in this location if the patient was standing straight and he would have come too forward. You know, it's like somebody coming too close to you to talk to you. So he's coming in straight and the head is not bent. Then the entire face of the person would be too bigger. So the lateral border of the mandible and the condyle and out here would be too much in front. But if the patient bends down his face, that is the chin area, like you're looking down, then still there would be gap out here like it is there, but the chin would not come in the picture. You understand? So if at all you get confused in the options that the patient is coming forward or the patient is bending down, remember that if the patient had come too forward, then both the borders of the lateral border of the mandible would be out here. That is the edge of the phlegm. And the entire picture would be a very bigger picture. It would be a magnified version. But if you still see gaps, as in there is a margin and you can see this and complete border of the mandible with gaps in the phlegms, but you can't see the lower border of the mandible, that means the patient has tipped downwards. That is his facing down, he's put his chin down. Understood? There are many other errors of the OPG which are also asked, which we will come to in the next sub questions. So now when you see this OPG, you understand what I mean. So I'm already a little prepared for the questions which are going to come even before I see them. This is how you should picturize. You should not just see the OPG and jump directly to see the sub question. Take a moment. Getting my point? So let's go down. Now what is the error in this OPG? So we have the option of chin tipped too low, chin tipped too high, patient is too far back and patient is too far forward. If the patient was too far back, then this image would have been a little smaller, you know, like it's very far. There would have been more gap between this margin. So it's not that the patient is gone too far back. Chin tipped too high. Now in this scenario, what would happen? This lower border of the mandible would have been visible. Chin tipped too high means you're looking upwards, you know. Just take your face and look up to the ceiling. I'm doing it as well. And you'll see the chin is up. Now if the chin comes up, it should be visible completely out here. It cannot be like so low near the phlegm. The chin would have been somewhere at this area. That is not the scenario. So now the other two options are chin tipped too low, which we discussed, and patient is too far forward. So I understand if you're confused between the option option A and option D. But like we discussed, if the patient was too forward, this border of the mandible would have been out here and here. And the chin would have also not been seen, but since the border of the mandible is here and we have a nice gap between the phlegm, the answer becomes chin tipped too low. Understood? So this is how you should eliminate the options even if you feel whatever you have chosen is the correct. Just to be double sure in marking. It's a very expensive exam. It has taken a lot of precious time. So do not rush into answering. You have approximately 2 minutes to answer each question. Use those 2 minutes. Don't directly jump to the answer in 10-15 seconds, mark and move ahead. Okay, so let's go on to the second. Yeah. What is the structure indicated by the arrowheads. So now, before even I see the arrowheads, I'm just trying to see what is this picture. I understand it's a perioapical view. Then I understand it's a molar area. So immediately when it comes to the upper molar area, I feel, there has to be some sinus or some things. And when I see the arrows, I understand they are asking about an anatomical structure, because I don't see any pathology as of now. Now when I see the straight line, two things can come into my mind. It can be either it can be a sinus line or it can be the hard palate line. Understand? Now when I see the other lines out here like this and like this, I understand that the sinus line cannot be straight. It has to be wavy. So I will rule this as a sinus line. But what is this line? It has to be the hard palate then. I am saying this in absolutely simple terms, assuming you don't understand anything of IOBA, So if you understand the anatomical structures very well, but as a graduate, a recent graduate, if you have difficulty, this is the way to rule out your options. So it's still blurry, the screen, like it's very clear for me actually. If you can take a screenshot and send it to me, I will understand how much blurry that is for you. But anyways, let's go with the options. The options are hard palate, floor of the nose, roof of the sinus, A and B and B and C. Now in this question, if you jump and directly go on to answer, it's the hard palate. Wrong. Because they have given the option A and B also. Now see, the hard palate is nothing but for ENT people, it's the floor of the nose. So both the options are correct here and they have given this option. So if you were in a rush seeing, okay, I see the arrow marks and I feel that, it's just the hard palate and I just mark A and I move ahead, then I will fail in the exam. I'll fail this question, not the exam per se. But if I clearly read all the options and I see, oh, the floor of the nose is also the hard palate, then I will answer the option as D, and then that becomes the right answer. Understood? Clear? It's a game of patience. It's mostly a mind game. I'm just checking the picture that is sent to me as to how much blurry that is. Just give me a second. Oh yeah, it's pretty blurry for you all. Why is that? See, then I don't have any other option to take except for Facebook Live, because if I take just a Zoom session, it would be just for my enrolled candidates, because I cannot include all the other people out there. So I really don't know, because this is the Facebook screen recording, like the sharing screen option. But it's okay, even if it is a bit blurry, I hope you are able to understand when I read out the options. Are you able to understand it at all, or you're not able to understand it? What the enrolled candidates can do, they can open the mock 14 so that they can have the clear picture of the questions, because I've taken that mock and I'm answering that. The other candidates have to just bear through, So that helps. So anyways, I'll move on to the third question. Any doubts about this question, feel free to ask me. Go ahead, I'll give you a minute. Write in your doubts. Anybody writing? No doubts? If no doubts, just write a no and I'll move ahead. Guys, you all there? Can you hear me? Somebody write a yes or no, please. Nobody is writing anything. How am I supposed to know you people are there or not? Huh? Hello. Yeah, the comment is on because I just wrote a hi to myself. Should I proceed with the next question? No doubts, all good. I'm audible, I can proceed. Okay, thank you so much. Let's go ahead. What are the radiopaque circular objects on the distal superior left side near to 8? So what the question is asking. So when I read this question, I will directly jump onto the area which they have mentioned. That is the distal superior left side. Left side is this. This is his distal and the superior side. This area basically. So they're asking what is this. So first, even before reading the options, just look properly. And when you see such an area, you imagine a normal OPG in your head. And then of course, you know, this is not a normal area. Even if you're supposed to think, okay, it may have been the, you know, condyle or the coronoid, it doesn't look like it. So when I see this and when I see structures like this, okay. Now let me read the options. Options are ghost images of screws and plate. Where are the screws and plate? Here. Can it be a ghost image? Yes, it can be. Antral calcification, well, if it was antral calcification, it would be just in this area. It cannot go all the way down till here. Salivary gland stones, even if I'm mistaken this for a salivary gland stones, there is no way there can be a stone out in this area. There is nothing in this area. And salivary gland stones don't look like this. They look like small radiopaque dots. And they would be either in this parotid gland or either it is submandibular gland or the sublingual gland out here. It cannot be this entire area can be full of stones, you know. So I'm eliminating the options here. And then developer artifact and X-ray holder. This is an OPG and the X-ray holder is here. There cannot be any other X-ray holder out there. And developer artifact, I can think about it being a developer artifact. No doubt that can be a right option, but when I have this option of ghost images of screws and plates, I will choose this option. In case I did not have that option, then I would go with a developer artifact. So what in the exam they can do, they can give you the same image, but they can change the options. Because see, ADC people are very smart. They understand that people out there know the questions that have been asked. So they'll ask the same question, but they'll tweak it a little bit. You understand? So the keywords become very important for you to read. You cannot memorize the ADC questions. It's no longer the same one. They want to analyze and they want to see how much you are capable of spontaneous thinking in various scenarios, which is a very good way. So this is all the ADC questions which have been asked, but don't expect exact same words in your exam. It can be little tweaking here and there, which is okay, and you should be confident because you know how to approach them. Understood? So here the answer would be ghost images of screws and plates. Understood? If this option was not given, then I would have chosen developer artifact. Clear? I'm moving ahead. Alright. Now a male patient, 38-year-old, who has worked in military. Military here becomes my keyword, I remember that. Comes to you for consultation regarding his lower right premolar. Alright. He is asymptomatic. Now this asymptomatic is a major keyword, meaning he is not in pain at all. So he was in military and he is not having any pain, but he's come to you about the right premolar. Now I took a radiograph and I found a radiolucent area extending from 4.3 to 4.6. Like pretty big area, around 2 centimeter or 3 centimeter. Now I'm finding a radiolucent area. A radiolucent area, what can it be? It can be either an artifact, it can be a fracture line, it can be a cyst, it can be a tumor, correct? Or it can be a big abscess. Now what is the most likely diagnosis? So I am thinking of these many differential diagnoses. Now to reach to the right answer, I have to eliminate them. Now let's see the options. First is traumatic cyst. What is a traumatic cyst? The area was hurt and either it's filled with blood or it's filled with an air cavity called as a Staphne cyst. So can traumatic cyst happen? Yes, it can. Why? Because he was in a military, high chances of getting injuries. And usually the history of traumatic cyst are there, they are found accidentally and they are asymptomatic. So it fits my criteria. But I'm not satisfied right now because I still haven't seen the other options. Now I go with dentigerous cyst. Well, dentigerous cyst, can it be a possibility? Yes. But then what it would cause? It would cause deflection of the teeth from either side. There would be a swelling. It cannot be an asymptomatic lesion. So that's out of the question. Odontogenic keratocyst. Odontogenic keratocyst, yes, it can also happen, but again, there would be deflection of the roots and there has to be one tooth missing. The question does not mention any teeth missing, so I will not choose that. Aneurysmal bone cyst. Well, this is a very close possibility because it can be an area which is filled with blood. But again, in that scenario, there has to be some symptoms. Or even if it is asymptomatic, then I would have to choose between traumatic cyst and aneurysmal bone cyst. Now, in case this question would not have mentioned the keyword of military, I could have marked aneurysmal bone cyst and it could have been the right answer. But since they have mentioned the word military, I am going to go with the traumatic cyst. Now, in the exam, there are 40 unmarked questions, and they purposely keep it unmarked is because there can be two options correct. And when two options are correct, they make that question unmarked. This I had clearly asked in my candidate reference group meeting, and she explained to me in detail why they choose to make it unmarked, and it's not pre-decided before the exam is conducted. Once the examination has finished, they look at the answers, and if they feel majority of the candidates have marked the same two options which look very similar and either of them can be correct, after the exam they make it unmarked. You understand? So in this question, for example, even if you were to go with an aneurysmal bone cyst, it wouldn't be a wrong answer, but I would go with the traumatic cyst. But in case you did mark, and if they chose to make this question unmarked, it's all right. Like, nobody gets marking for this anyways. So yeah, I hope this point is understood. I'm moving on to the next question. After the next question, I'll let you ask all the doubts before I move to the next SBQ, and then you can ask me all the doubts that you'll have. Now again, I see a picture. Now this patient has a finding at the apical region of second premolar. What is your assessment? Okay, so I see the second premolar, I see the apical area, which is this area, and I see some teeth-like structures. Immediately I know it's an odontome, but which one? Complex or compound? So now I have to go back to my basics. See, basic dentistry is something which nobody can teach you. If you're confused, like you don't know what is a complex odontome. For example, let's say you are indeed not aware of what is a complex odontome. It's fine. You know, just brush your basics. Come on Google, type complex odontome X-ray. So here is one of the pictures. Do you see this structure? Like so many of them, and barely you can recognize, like they look radio opaque, but it may not be exactly looking like a tooth. It can be just blobs of, you know, radio opaque stuff. And now let's see compound odontome. Now when I see a compound odontome, for example, yeah, picture like this, I can make out a bit of the teeth structure. You know, even this looks like a complex one only, but if I see even one of them as a good tooth-like structure, I would go with a compound one. Or for example, even this one. You see? Again, this looks like a blob, but you can actually make out the enamel and the dentine a bit. So it looks more like a compound odontome out here. Also, you need to remember the areas where complex odontomes are more often seen and compound are often seen. So since here it's clearly looking like say a small canine like a structure, you can actually make out a root. If it was just small blobs like this, I would have gone with complex. But since it's looking more like a root structure, I'm going to go with a compound odontome. So, and now I see the options. I have compound odontome, I have complex, I have idiopathic osteosclerosis, which I don't think so is the answer. I have dentinonorma, again I don't think so that's the answer. So all I can do is can be confused with compound and the complex odontome, and I choose to go with the compound odontome. So I'm going to mark this out here. Okay, and I'm going to proceed with my next SBQ. Minutes to ask me any doubts that you have. about this or anything else, go ahead. You have your 2 minutes. Any questions before I start with the next SBQ? I'm waiting for you all to ask me any question. If not, I'll proceed with the next SBQ. Can proceed. Okay, nobody's asking me any questions, so I assume it's pretty clear. Let's proceed with the second. Now, the second question is also very, very important. And that is because this question will 100% be asked in your exam. In fact, 2 or 3 questions on the same topic can be asked. They love MRONJ, MRONJ, that is medication-related osteonecrosis of the jaw. Do read therapeutic guidelines about it. It's very important. And the scenario of the question can be almost similar. What they'll be asking whenever they ask this question is when you're going to do the treatment if the patient is taking an injection, and what kind of treatment can you do if the patient has taken an injection, and what are the complications that can arise. And mostly the patient will be upset that the previous dentist did not tell them about the side effects of taking the injection if they were supposed to do a dental treatment. So what are you going to do about it? So the questions will always be similar in this category only. Okay. So it's okay. Just make sure you know your basics correct, and then you can answer any question related to this topic. So let's see. A female patient came to get her dental clearance done before starting denosumab injection, okay, for osteoporosis as advised by the doctor. I'm sure you know what osteoporosis is, and denosumab, the brand name is Prolia. It's basically given to stop the resorption of the bone because already the patient has osteoporosis. Now, sub-question 1. Which other supplements is she most likely taking while undergoing the treatment? Treatment for what? Treatment for osteoporosis. Osteoporosis is what related to bones. What is required related to bones and the supplement. Now, parathyroid hormone is not supplement, okay? So that is out of the question. Omega-3 fish oils, well, it's a supplement, but is it given exclusively for osteoporosis? No. Vitamin D is very important. All of us know vitamin D is very important for our bones, and yes, this is the most likely supplement. There can be an option of calcium also, but still you will choose vitamin D because vitamin D is necessary for absorption of calcium. So the option becomes vitamin D. If in case vitamin D is not given and calcium is given, then you can choose the option as calcium. Second question. What is the complication that can occur if extractions are done while the patient is on denosumab? Now here most of the people get confused. They feel, is it MRONJ or it is BRONJ? See, BRONJ is bisphosphonate related necrosis of the jaw. MRONJ is medication related osteonecrosis of the jaw. Denosumab is not a bisphosphonate. It's another medication only. So you have to choose MRONJ. But if they had given another name of another medication which was bisphosphonate, then you could have chosen BRONJ. Understood? This is very, very clearly mentioned in therapeutic guidelines. So you should not be confused. Hence, I always keep on insisting, read TG. No matter what happens, 5 times read therapeutic guidelines, you know. Patient taking denosumab every 6 months. had to go scaling and root planing as part of a regular maintenance plan. When should the treatment be done? All right. So now denosumab is an injection which is given every 6 months, and she has to go scaling and root planing. Scaling and root planing both involve bleeding of the gums, and wherever there is bleeding of the gums or any injury, we don't want to do that if the patient is on this medication. And it's actually the same if the patient is having hemophilia or having some other bleeding disorders as well. You try to avoid, because healing becomes a lot difficult. So in all the scenarios, when should the treatment be done? So in the case of denosumab, the treatment should be done within a week before the next injection, because at that point of time the effect of denosumab is the least in the body. So the healing will take very nicely. Perform treatment just after denosumab? No, that has the highest dose of denosumab. So healing would be a lot delayed. As in, it can be risky. It's not necessarily it would be delayed, but why do you want to put the patient at risk? So option A is not correct. Option B is correct. Option C, on the day of giving denosumab, no. I mean, if I did not have the option B, I may have chosen option C. But let's say option D. 3 months after denosumab, if I did not have option of C, then I would have chosen the option D. 1 week after denosumab, no. So anything which involves on the same day or 1 week, no. Anything which involves before a week or after 3 months, yes. So not necessarily all these options would be given in the exam. They can give some other options also, but you are supposed to use something in which the level of denosumab will be very less in the body when you are doing the treatment, so that healing can take place very nicely. Understood? Now her previous dentist did not tell her about the risk of osteonecrosis of the jaw. Now she was very upset about it. Now this question is related to the professionalism cluster. What is the most appropriate way to handle this situation? Now I've also made a video about this which is there on YouTube. My hierarchy of choosing the option is always ask the patient for the permission, and after taking the permission of the patient, contact the previous dentist, understand the scenario, and then only give a comment about it. If this option is not given, then you will tell the patient, please go back and talk to your own dentist. If that option is also not given, then you can just tell her she has the right to do, like complain about it in case the patient asks. But this is not the first option you would go with. And definitely you will never by yourself report to any authority. Understood? Or threaten the other dentist or tell them that the complaint is going to come against you. That is very unprofessional. Just imagine yourself in the situation. A patient comes to you and tells you that, the previous dentist did not tell me he did this and that, and you say, oh, you will not start belittling the other dentist. He's your colleague after all. What you can say to the patient, if you allow me, I would like just to ask the scenario. You are not sure if the patient is telling you the truth or not, then how can you blame the other person? You need to know the both sides of the story, but only after the patient allows you. But if that option is not there, then you can tell the patient you can go back and talk to your own dentist. Most of the people fail in the professionalism cluster because when these two options are given, that after taking the permission from the patient, you can contact the dentist, or the option of ask the patient to go back to the dentist and talk yourself. If these two options are given and they choose the option of go back to your dentist and talk yourself, no. You should always choose the first option, that is take permission of the patient and talk to the other dentist and understand the whole scenario. Okay, because you never know what the patient is going to go and talk to the other dentist. He may go and tell the other dentist, you know what, the dentist that I went to is saying this and this and you didn't tell me. So again, that's a bad thing. So if option 1 is not given, then you choose the option 2. Watch my video on the YouTube. I have explained the scenario in detail. So in this question, what are the options? Advise the patient to talk to her previous dentist by herself. Okay. You talk to the previous dentist to get clarification and warn them about potential complaint. Now, this does look like I'm talking to the previous dentist, but it does not mention that I've taken permission of the patient. And it also mentions that I'm supposed to warn them about the potential complaint, which is wrong. So I will not choose this option. You report to ADA, absolutely wrong. I report to AFRA, absolutely wrong. Advise her to seek legal action. This is me instigating them, absolutely wrong. So I'll choose the option A, advise the patient to talk to her previous dentist by herself. Got it? Understood the logic behind it? Now, which dental treatment can be safely performed in the patient while on denosumab? Which means that the patient has already taken the injection. Now, which things can you do? You should do anything which does not involve bleeding. So, already this is in my mind that I will do anything which does not involve bleeding. So, all I have to do is eliminate the options which involve bleeding. Extraction, it involves bleeding, so I will not do. Subgingival scaling, yes. Supragingival scaling also involves bleeding sometimes. So, composite restoration, I understand. Many people can say, what if it's a class 2 restoration? I have to put the matrix band. What if it bleeds? Well, why do you want to directly jump on a class 2 restoration? It can be a class 1 restoration where there is literally zero bleeding. So I would choose that option. Some people might say, why not supragingival scaling? Oh, well, supragingival scaling does cause sometimes bleeding, and you all must have experienced that many times. So unless they have specified it's a class 2 deep subgingival composite restoration, if they have just given the option as composite restoration, go with that. Understood? So there I've solved 2 SBQs. I will solve others in the next couple of weeks again when I'll hold the session. But right now I want to answer any doubts that you all have before I make a move. So please feel free to ask me any doubts related to this exam, this question, or anything that you want me to ask. You need a motivation, you want to describe your situation, you're having any difficulty, go ahead, ask me right now. I'm waiting for your comments, guys. Anybody writing anything? I'll give you 2 minutes. No questions? Sure about that? Can you all hear me? Okay, so all the comments are coming here on the Facebook. I just cannot see on my phone. Understood. Okay, let me go back to all the questions and see it again. Okay, I'll start with Huma's question, difference between dry socket and post-operative dental infection. In dry socket, you have to have the history of having pain in especially the lower mandibular wisdom tooth, that too after 3 to 5 days. Okay, and the question has to mention that you can see the bone and there is no visible blood clot which is present. Understood? So, and post-operative dental infection, you have to see the clinical examination if the clot is still present, because it will have almost the similar features as dry socket. So you have to have a clinical look if the blood clot is present or not. Absence of a blood clot is definitely dry socket. Presence of a blood clot and then fatigue, odor, pain, infection, bleeding is post-operative dental infection. So if the blood clot word is not mentioned, then both the diagnosis can be correct. Understood? The main feature of complex odontome is that you can't differentiate between dentine and other structures. Correct. They are like just small blobs, But in compound odontome, you can actually see it's like a tooth-like structure. It's not just blobs of radiopaque structures. Then I will come to Please explain the common areas of complex and compound odontome. I'll have to go to the oral pathology and read more about it, to be honest. But usually the compound odontome, you know what, let's do it now. Compound odontome features. I'm going on Google, but you're supposed to open your oral pathology. Common areas. What is the most common site of compound odontome? Yeah, as I thought so. See, anterior maxilla, like till the area of premolars, is a site for compound odontome. But complex odontomes usually happens in the molar areas. This is what I have remembered for my this thing. But you can read more about it. Open your Schaefer's, open any other oral pathology book and read more about it. But the basic crux is in compound, it will not be more than 4 or 5 structures of the teeth, while in complex you'll have more than 10, you know. So this is also a good point to differentiate. In compound you'll have 2, 3, 4 or 5 max, not more than that. Now Pritika is asking which form of topical fluoride should be avoided with patients with allergy from band-aid adhesive, tooth mousse. Yeah, this is a very strange question actually. Tooth mousse is CPP ACP. It has to be avoided in dairy allergy. Varnish can be avoided in band-aid adhesive if the patient is having allergy to band-aid adhesive, because varnish has those adhesive things. But I will not choose tooth mousse for band-aid adhesive. I will choose varnish instead. Can I give lecture on LA? You'll have to be more specific. Like, what about LA? Like, what about local anesthesia you want to know? Like, you want to know the ingredients, you want to know how it is given, or can you please specify more, Huma, please? Divnesh is asking for patients taking warfarin, what INR would be ideal for extraction? Between 1 to 4. So, if the option mentions 1 to 2 to 3, 3 to 4, then I would choose 2 to 3. Because already they have taking warfarin, you cannot expect their INR to be just 1. It has to be more, but it should be within controlled ranges. So max you can go till 4, but ideal would be 2 to 3. So I would choose that as my answer. But again, guidelines keep changing, you know, and we don't know what Australian people follow the guidelines. So far they're following therapeutic guidelines, so just stick to that. Then which is the other question? About dose and which LA is given in certain conditions. Okay. See, dose of the LA depends on, okay. Right, take a piece and paper and write it down. If you are giving, I'm talking about lignocaine out here, only lignocaine, because other LAs have different dosages, but most of the time other LAs are not asked, they'll ask only about lignocaine. So take a pen and paper and write it down right now. For lignocaine, if you're giving plain lignocaine, the maximum that you can give is 4 milligram per kg. Okay, and I'll tell you how it works. And if you're giving lignocaine with adrenaline, it is 7 milligram per kg. So how it is calculated is, suppose the patient is 20 kg. So 4 into 20 becomes 80. You divide it by 2. So 4 ml of lignocaine you can give. And this is, I'm saying, for a 2.2 cartridge, 2.2 ml cartridge. So in 2.2 ml cartridge, in one cartridge, how much LA is there? You calculate that by 2.2 into the percentage of the lignocaine. So it becomes quite complex. So for me, the easy calculation is, what I do is, if I have a patient 20 kg and I'm giving him plain lignocaine, I calculate 4 into 20 is 80 divided by 2. That comes to 4. So 4 ml is maximum that I can give. Now, if I'm taking a 2.2 ml cartridge, I can give him maximum 2 cartridges, but it would still become 4.4 ml. So I will give 1.5 cartridge to him. If my cartridge is 1.8 ml, then I will give him full 2 cartridges. That's the maximum dose I can give. Understood? Now, if again the patient is 20 kg and I'm giving lignocaine with adrenaline, I can give 7 milligram per kg, which means 7 into 20 becomes 140. Divide by 2 becomes 7. I can give 7 ml. This is the most easiest calculation. So that's why I write it down, or I'm going to record this video anyways and post it so you can listen to this part again. This will help you in clinical aspects also. Now I'm doing this calculation basis assuming I have a 2% lignocaine. Now if the question is mentioning you 3% prilocaine or 4% benzocaine, then the calculations are entirely different. Understood? But they usually don't ask that. Mostly they will ask only about the lignocaine. So this is the most easiest way to calculate. So stick with this calculation. Certain conditions, well, see, as of the current guidelines, lignocaine pretty much can be given everywhere. Adrenaline can be given pretty much everywhere except if the patient mentions that they have adrenaline allergy. Now this LA, you know what, part will become very important in your part 2 exam. Very smartly, they'll give you the LA task. They'll not say anything because it's a skilled OSCE. And on the medical history that's mentioned out there, which you are supposed to read and don't forget it, it would be mentioned that a patient has allergy to adrenaline. It's written in very tiny letters on that paper, adrenaline, and there will be tick mark that the patient is allergic to it. So of course you cannot pick up, and they will have kept the 3 cartridges out there. One would be Citanest. You need to remember the brand out there. Citanest is Felipressin with prilocaine, and there would be a plain lignocaine, and there would be a lignocaine with adrenaline, So you have to pick up Citanest in that scenario. So anyways, for LA, just remember this, that this is the dose, and you can give prilocaine and Felipressin, and you can give almost in every other condition lignocaine. Adrenaline can be given if the patient is not allergic. Don't give adrenaline if the patient is having sorry, I sneezed. If the patient is having hyperthyroidism, because then adrenaline can cause toxicity in that scenario. Or yeah, like this. Yes. So this is the simple scenarios which you're supposed to remember. Now Mahmood Vakil is asking, a question was asked in March exam about patient with sensitivity to milk, and they mentioned the option of rice milk. When you say milk, they consider it as dairy. Now you have to be giving me more about this question, like what they asked, like what they wanted out of the options. But if you're saying sensitivity to milk, it's dairy. Rice milk is not dairy, so you can give. Almond milk is not dairy, Mock test on infection control. Patient with viral influenza should not have elective dental treatment while they are infections for a duration of 2 weeks for all patients, but isn't it 3 weeks for the age of 12? Yeah, it is. I know this mock. I know this question. It is. See, what happens is in, say, infection control also has, different editions. Some of the edition mention this and some of the edition mentions that, but you follow the latest edition. It's really difficult to keep on correcting the answer based on the new edition that comes out, because you never know, is the ADC has the ADC started to follow the new edition or not, and some of the things are not mentioned in the previous edition or the latest edition, and they still ask questions about it. So don't blindly go on the answers which are provided. If you feel in the doubt, you follow the latest edition and you mark your own answer, and then you stick to it. You understand? So if the latest edition is saying 3 weeks for the age of 12, then go for it. Okay, so the question here, don't just focus like exact words on the question here. Understand that this is a kind of question that can be asked. So if I tweak certain ages of this, now if example I say the question is of about 16-year-old, you will directly choose 2 weeks. If I say the question is for like 8-year-old, you will then choose 3 weeks. You understand? So here focus on the guideline that is provided and then match the age and do it. I hope this is clear, Gitanjali. Yeah, any other comment? I hope I've answered all the questions so far. What is the age range for adolescents? For what? You're talking about the influenza or about what? Can you be more specific? Mahmood? Age range for adolescents for what? Like, what is your question? You're welcome, Gitanjali. I hope I've not missed any other question. No. Read more about mouth guards, guys. A lot of questions have been asked about mouth guards. Any other difficulty you're having? I'll end the session. Can you please upload this live? Oh yes, of course. I would. Acha, the age range for adolescents you're asking. I got it. See, adolescent, I would start from 12 years actually. I wouldn't count a 10-year-old as adolescent, to be honest. And I would take them from 12 to 17, honestly. 18 in certain countries it becomes adults, so I'll stick to 17. But again, you should read the rest of the question also. Sometimes they're asking something else, you know. Now, for example, 16 is the age where I think in Australia they learn to drive. But in India, they won't allow you until you are 18 or 21, something like this, you know. So every country also has a different range. So depends on what the question is asking about. Gitanjali is again asking, I would like to know what should we read in orthodontics? Canine impactions. The ways of getting the canine out when it's impacted, missing lateral incisors, what would you do? You would refer, you would do what kind of treatments, what are the options available, because this is all going to be asked in part 2 as well. You know, part 1 and part 2 are quite linked. So now that I've given part 2, I understand what ortho questions they ask, and they can ask in part 1. So they will ask you about the bite. Yeah, they'll give you a nice clinical picture and they'll ask you which bite it is. End on, mesial step, distal step, class 1, class 2, class 3. You should know the bites in relation with the canine also. I know we just check the molars, but you should also check the canines. So that they can give you a lateral cephalogram also and ask you which kind of a bite that is. No need to remember the tracings, but just remember the important landmarks like Nasion, Pogonion, Nathion, Sella turcica, Frankfurt horizontal plane, mandibular plane, just the major ones. And what else in ortho? Mixed dentition, and yeah, that is pretty much about it. And when to refer to ortho. Yeah, don't even if you are an orthodontist who is giving an exam, behave you are a general dentist. Yeah, pretty much. So I hope this is clear. I'm ending the video now. Any more questions, just then leave in the comment section and I'll apply it later. Most probably I'll having another session next week on Sunday itself. And I'll be more active now for part 1 on my enrolled candidates group. I'll be posting questions and I'm available now, like my exam's done. So I'm all about part 1, and yeah, I'm very close to, I have almost 150 to 160 questions of the March exam. I'll be preparing a mock about it soon and giving it to you so that you have ample time to prepare before your own exam. So yeah, I'm just, you know, it takes a lot of while. You know, it's so difficult to gather all the questions from all the candidates, and so many have different versions of the same questions. But again, like I said, it's knowing which topics rather than mugging up the questions, you know. So yeah, I'm doing my best to help you all out. It really takes a lot of tasks to do it. So yeah, have a nice day. Take care, guys, then. Bye-bye.